When people bring up concerns about the affirmation-only approach to children with gender dysphoria, which involves social, medical, and surgical transition, we are left to wonder, what do the critics think should be done instead? The kids are real. Their distress is real. Should nothing be done? The term watchful waiting is often used, but that sounds like doing nothing. Is that really all we can or should offer these kids? Watchful waiting doesn't mean doing nothing for kids who are in distress. It's an older term for a process that's now more commonly called exploratory therapy. It isn't that simple, though. The idea that affirmation may not be the right choice for every child, and that there is a role for understanding a dysphoric child's history and underlying psychological issues, is itself controversial. Some critics equate it to the unethical practice of gay conversion therapy. So, exactly what is exploratory therapy for gender dysphoric kids? This question was directly addressed in a January 2023 live stream by mental health professionals from the Gender Exploratory Therapy Association, hosted by the Foundation Against Intolerance and Racism in Medicine. This video is an excerpt from that presentation, Exploratory Therapy for Kids with Gender Dysphoria, What It Is and What It Isn't. Make sure to check out the full presentation through the link in the description below.
I'm going to talk about the basic principles of what we think gender exploratory therapy is. Up until very recently, gender affirmative treatments were considered the gold standard treatment for young people with gender dysphoria. However, recently some questions are beginning to emerge about whether this is in fact the best treatment. And we have looked at the research very carefully in collaboration with SEGM, the Society for Evidence-Based Gender Medicine, and have also been very influenced by a number of independent systematic reviews that have been performed by Sweden, Finland, and the United Kingdom, which have all raised serious questions about gender affirmative treatment. And all of those reviews have found that the evidence is of low and very low quality, and that the risks do not outweigh the benefits. And those countries have all quite significantly curtailed the use of gender-affirming interventions in young people. In fact, Sweden now only allows those treatments to occur for the most extreme cases and in the context of a clinical trial. So those are very different ways of managing gender dysphoria compared to what is happening in other countries around the world, like the US and Australia. The other thing I just want to say at the outset, because this will certainly come up, and we've been to with this question many times, is that this is not conversion therapy. And I'm always struck when people talk to me about psychological treatment for gender dysphoria. People seem unable to imagine that there is anything other than, if you don't affirm, what do? You must be converting the person to turn them into a cis person. So what we want to try to highlight today is that there is another option, like affirmation and conversion are not the only two options for how to respond to gender dysphoria. That gender dysphoria is actually a very complex phenomenon, and each case is unique. And what we try to do is unpack and explore what is going on for each individual person to help them find the best solution for them. So looking at this slide now, as I was just alluding to then, exploratory therapy is open to a range of outcomes. So basically, this means that we're not trying to convince young people that they're not trans. We're not trying to turn them into gender-conforming cis people with conservative values who are heterosexual. That's not at all what it's about. We're actually really trying to begin a process of exploration and dialogue that will help young people understand themselves better and figure out how they want to live and what kind of life is actually going to be most liberating for them, and what kind of life will minimize the risk of any kind of harm. And we do know from a lot of the emerging research that there are risks associated with gender affirming treatments that are still emerging and are, we think, probably still unknown, given that this treatment for young people has only been around for a very small number of years. And on that, just going back to the research, and also we don't have any long-term follow-up studies that have followed young people who transition during adolescence well into adulthood. The longest term outcome study we have is one of the original Dutch studies, which only followed young people to around the age of 21. So beyond that, we don't know how these kids will be doing in their 30s and their 40s, and whether the outcomes will be good or whether they'll be problematic. Okay, this is really key, I think. Point two is that gender dysphoria emerges in a context. And what do we mean by that? This is a different way of thinking about gender dysphoria compared to the way standard gender affirming approaches think about gender dysphoria. In our conversations with many of our colleagues who take a gender affirming approach, there's a sense that gender is seen as an innate quality that just is. It's not something that needs to be considered or explored or thought about, or certainly not questioned. And we, on the other hand, as psychotherapists, understand gender as a subjective experience. It's a subjective internal experience. And like all subjective experience, it doesn't happen in a vacuum. Like, people are not just born with a particular sense of themselves. Our senses of ourselves develop over time as a result of social, family, formative experiences. And so gender dysphoria is no different. It's not possible to understand gender dysphoria without looking at the context in which it emerges. And so that means looking at the family, the developmental history, the young person's experience at school, relationships with peers, their particular interests, what's going on politically in their immediate environment. So there are a lot of strands that can come together. And the way I've written about this is that I see all of these things as intersecting factors and systems. And gender dysphoria is often like an emergent phenomenon that results when these systems come together in a particular way in each individual case. In our exploratory therapy, we really want to look at the entire big picture of all of these different aspects of each person's life. So this kind of relates to point three, which is that exploratory therapy is developmentally informed. We feel it's problematic to see gender as just an isolated phenomenon without looking at it in the context of what is going on developmentally for each individual. And when we spend time talking to young people with gender dysphoria, we often find that the trans identification or other gender struggles are often very intertwined with kind of pretty normal developmental struggles and stresses. For example, separation and individuation is one of the central tasks of adolescence. We all know that adolescents become defiant and want to define their own rules and do their own thing and be their own person, which is something that we encourage and applaud. But sometimes gender dysphoria and trans identification becomes recruited to manage that struggle when the young person is experiencing difficulty separating or asserting their own identity. And it's so important to actually spend some time really understanding the young person's history and where they're at developmentally before we make any assumptions about whether their stated gender identification really represents something that is enduring, or whether it's actually something that serves a function in that person's life to help them manage other more complicated stresses and difficulties. Point four, okay, we consider and address comorbid conditions. Again, just to point out how we think about this as psychotherapists, is that comorbidity, it's now very well known that gender dysphoria is highly comorbid with a range of other mental health problems. Things such as anxiety disorders, depression, eating disorders, neurodevelopmental disorders such as autism and ADHD. So there tends to be, at least in the lay press, and also I think amongst many clinicians, a belief that these kinds of comorbid problems are all secondary to gender dysphoria. so that minority stress or the stress of growing up as gender diverse results in problematic experiences, which then lead to depression, anxiety, etc. Or somebody who is not able to live in their true gender as a result of that will develop depression or an eating disorder, etc., to manage those feelings. That is a possibility. However, it's really much more complicated than that. And in some ways, things could be the other way around. We have often found that gender dysphoria is a way of attempting to manage other difficulties, such as depression, anxiety, identity disorders, and confusion. We don't necessarily like to think about comorbidity as separate encapsulated conditions. So one of the problematic ways that our mental health system has evolved is that we often see people with a list of diagnoses, and there's no sense that these are all occurring in one person, and they're all most likely to be part of a big picture global response to whatever this young person has experienced or is struggling with in their life. So comorbidity is very important, but it's also important to not forget that all of these problems that young people come to us with are likely to be fundamentally related. Okay, sexual development and gender identity. This is a very important issue. Many of us working in this field have found that many of our patients have kind of anxiety or conflicts around sexual orientation. I myself found it surprising that, considering where we are in the 21st century and how far gay and lesbian rights have advanced, that many young people are still extremely ashamed and conflicted about same-sex attraction. So it's often not apparent at first, but after kind of spending time with young people and exploring how they feel about their developing sexuality, it's often shocking to hear really a lot of internalized homophobia. And in some cases, trans identification is the way to try to deal with that. In fact, a young patient once said to me that this was a natal female who identified as trans. Initially, she discovered she was attracted to other girls and thought she was a lesbian. However, really struggled with that, felt very ashamed. She was bullied. She then decided, or she realized, that she was trans. And she said to me, after some time exploring this, that being trans was much more socially acceptable for her than being a lesbian. I know it sounds shocking, but these kinds of biases and prejudices are much more widespread than I think any of us would like to realize. Okay, number 7, it's a process that occurs over an extended period of time. We often hear about young people attending gender services where, I don't know, at best, they may have 4 to 6 appointments before they're commenced on gender affirming treatments. And I'll add gender affirming treatments, in case any of you don't know what they are varying combinations of social transition, which means helping the young person change the way they look, changing their name, changing their gender signifiers, the way their name is recorded and their gender is recorded at school, and so on. That is sometimes followed by medical gender affirming treatments, which are either puberty blockers, which halt the development of secondary sex characteristics, or cross-sex hormones, which then precipitate the development of cross-sex secondary sexual characteristics. And although surgical interventions more commonly happen during adults, young people, including adolescents, are having gender affirming surgeries as well in small numbers, including mastectomies. So we see young people, we hear about and see young people who have had a small number of appointments with a psychologist or clinician at a gender service and then are approved for gender affirming treatments. We, just having worked as therapists for a long time, understand that developing a complex understanding of any human being cannot occur in 4 to 6 sessions. It takes a long period of time. It takes the establishment of a kind of safe trusting, and relatively close relationship with the therapist for the kinds of complex issues that we need to unpack to emerge. You can't do this in a handful of sessions. It's a process that occurs over months, years. And I just want to point out that the concern that what we're promoting here is conversion therapy. Often one of the criticisms we hear is that we don't allow young people to go on gender affirming treatments until they've had endless years of therapy. That is simply incorrect, as you'll see from our case example. But we do not stop people from having gender affirming treatments. We raise a lot of questions about it and make sure they understand what they're doing and why. But ultimately, we respect patient autonomy, and it's not up to us to act as gatekeepers or stand in the way of what young people ultimately decide to do in conjunction with their families, of course. Number 7, the issue of suicidality. Many of you who work in this field have probably heard that suicide is highly overrepresented in trans youth, and it's an extreme risk, and that if we do not immediately provide gender affirming interventions, young people will be at risk of suicide. That is simply not supported by any evidence. In fact, most seriously, we do not have any convincing evidence that gender affirming treatments reduce the risk of completed suicide. There is no evidence that it does that. We may have some evidence that there are short-term reductions in suicidal ideation, but overall, the risk of suicide continues through the transition process and even after the transition process. So as therapists, we have complex and subtle, tailored ways of helping young people manage suicidality. We don't need to initiate irreversible and serious interventions to help people manage their suicidality. Finally, informed consent. So we don't think young people can really provide informed consent to these serious treatments unless they actually understand why they want them so much, where this desire and distress is coming from, and unless they've actually spent some time thinking about how gender transition will ultimately help them. And that involves also thinking about the risks, the unknowns, and the potential problems. And so we also think it's important to be very honest with young people about the research and about the very low quality evidence that we currently have. Without that, informed consent just can't occur.
Thank you, Roberto. That was really thorough, and I think that probably covers really well some of these points as well. So I'm just going to touch on what exploratory therapy is not. And as Roberto discussed, it is not conversion therapy. And just for a little context here, conversion therapy is a term that describes a type of intervention or practice of attempting to turn homosexual people heterosexual. And thank goodness the field has come a long way, and this is very much considered not only unethical, but it is known to be ineffective and is no longer practiced. But what's happened in more contemporary times is that this label of conversion therapy has been applied to any type of therapeutic interaction or relationship which attempts to help a young person or any person with gender dysphoria explore what the meaning behind it could be, or anything essentially that is not a concretizing or an affirming of their stated gender identity. So this has been really unfortunate because it conflates two very distinct practices, one being an attempt to convert a gay person to a straight person, and any attempt to just simply help an individual understand themselves better, particularly in the context of their emergent gender dysphoria. Number one, exploratory therapy does not attempt to convert anyone, and as Roberto mentioned, because it's open to a broad range of possible outcomes, there is no kind of predetermined goal that the therapist has in mind. Instead, it is a process. And as we know in therapy, processes follow the individual. And so it is not a conversion therapy. Number two, it doesn't assume that trans identification is universally adaptive. Within the affirmation model that Roberto has described, there is the assumption that if an individual claims a transgender identity or claims to have some other kind of gender identity, that it is the role of the therapist to follow the lead because the assumption is that it is adaptive and it is almost a way of allowing the patient's true self to emerge. And the therapist's goal is to stay out of the way of that process. But as we've touched on so far, human beings have very complicated and sometimes subtle ways of attempting to manage distress and conflict within themselves. And sometimes that can happen in the context of an identity exploration, especially one that is accompanied by a desire to radically transform their body, their sense of identity, their sense of self in the world, the sense of how they relate to others. So, transgender identification in some cases may be the most adaptive and expansive way for an individual to live, and we certainly have seen cases where that's true. But it's important that the therapist not assume that is true universally with every single person presenting with gender dysphoria. So that's why it's important to explore and give individuals a process because that will help them to discern whether their identification is adaptive or not. Number three, we don't assume that gender affirmative interventions are universally helpful. In addition to some of the points we've raised so far about the kind of ways that people may recruit a gender identity to manage their distress, there is also the biological reality of how challenging these interventions can be on a person's physicality. Whether or not a person's identity ends up being adaptive in the long run, individuals still really have to contend with the medical complications and the medical burden that they will accrue from being a patient, a medical patient for the rest of their lives. And these are really serious pieces of information that a lot of young people simply don't have. A lot of young people who are presenting in the clinics with gender dysphoria are under the illusion, sometimes unfortunately facilitated by adults and authority figures in their life, that it's a pretty simple process to take this or that medication, have this or that surgery, and then become your authentic self. And the reality is, even if those procedures may be beneficial and helpful to someone in the long run, there are many transgender adults who feel like they were not given the full picture of what medical complications may be waiting for them down the line. So we believe that in order to provide a true informed consent, we have to keep in mind that there's a potential that these interventions may actually be experienced as harmful by the individual rather than only be experienced as something that is helpful to them. And this kind of goes along with point number four here, which is that we do not encourage the obfuscation of biological facts. In the affirmation model that Roberto laid out, there is a lot of language which attempts to sanitize the complicated interventions that often accompany gender affirming care. So, something, for example, like top surgery is a euphemistic term applied to double mastectomy, or bottom surgery is often used for penile inversion and vaginoplasty or phalloplasty. And the truth is, these are incredibly complicated surgical interventions and hormonal interventions that many physicians claim to be actually experimental. So it's important working with a young person that they understand that a medical intervention or a round of hormonal treatments or surgery cannot biologically change them into another sex, that there are serious trade offs made with any kind of medical intervention, particularly those which have a poor evidence base behind them, which are experimental. And I would say, in addition to this, biological facts can also be important within the therapeutic context because sometimes young people may not have a full understanding of how their own biological realities impact things like mood, their experiences, their sense of distress. So, being really deliberate about clarity and honesty around biology is a really important part of gender exploratory therapy.
If you would like to learn more about exploratory therapy or find a therapist that approaches gender dysphoria from this perspective, visit the website for the Gender Exploratory Therapy Association at genderexploratory.com.